Xie Wu Hao. Good afternoon. My apologies. This is a rather grand title for my talk. If there's one thing I want you to get from that, it's please remember the pacemaker or defibrillator lead. Now, in terms of disclosures, firstly, I wish to apologize for my lack of ability to speak Mandarin. But I don't apologize for the fact that I am a lead extractor and I am involved with the European Working Party talking about tricuspid valves and leads. Now, I think everybody in this room has heard lots about the tricuspid valve being the so-called forgotten valve, and that's changed. We all know that severe tricuspid regurgitation has a mortality and morbidity, but what's changed is the fact that we can now treat that percutaneously, whereas before we had to rely on surgery, which had various risks and limited success dealing with very sick patients. So I think we've gone away from the valve being forgotten to a valve that's very much in the front of every mind at cardiology meetings. But perhaps what we've forgotten about is the device lead. And with all of the excitement about new percutaneous techniques, we've dropped the ball when it comes to pacing leads. And my message really is we need to consider that lead. Now, most of you know that device leads going across the tricuspid valve can cause damage, but there are other things that can cause tricuspid regurgitation, many other things outside of the device. But with a device, it's not just the lead, it's, for example, the programming of the pacing instructions, it's the potential for the patient to get endocarditis and so on, that means that we can have problems with our pacing lead and with tricuspid regurgitation. I think this is a useful concept here, that most people who have a pacemaker or ICD lead will be looked at in terms of tricuspid regurgitation. And perhaps 1 in 3 people might develop TR during their lifetime. But for most of those people, it doesn't really matter that much. But there's a group of people on the other side, on the right-hand side, where lead-related TR does matter, because the pathophysiology and the clinical course for those people is very different. And I think it leads to this difficulty we have with 2 different groups dealing with these patients. We have the heart failure community, the surgical and structural interventional group trying to treat TR when it occurs. But we've also got the arrhythmia doctors trying to manage the patient's arrhythmia needs without making TR worse or causing TR. And there's a list of ideas there about options to try and minimize the chance of TR. I talked about this last year with left bundle pacing. Professor Tsay may well talk about this later as well. The fact is, there is no optimal or consensus on how we can minimize TR related to pacing outside of these thoughts. So there are 2 issues that come up for a patient with TR. The first is, if they have the need for an intervention to treat TR, they have a chance of needing a device after their treatment. And depending on the type of surgery that's done, there will be differences in terms of the need for a device. We know roughly a half of patients who have tricuspid surgery will need a device at some stage. More so if they have multiple valve surgeries or other comorbidities. And depending on the type of surgery they have, it may make it more difficult to put a pacemaker or defibrillator device in, depending on what's done. If they have a mechanical valve, clearly you cannot put a lead across the valve. If they have a bioprosthesis, they could have a lead across the valve. If they have a repair like the top right, tricuspid annuloplasty, that may make it more awkward to use our traditional implant techniques to cross the valve. And clearly, if they have more advanced repairs of the leaflets, it may not be appropriate to cross the valve. Now, it doesn't really matter whether it's a surgical valve or a percutaneous valve. We have edge-to-edge repairs over here, percutaneous annuloplasties, valves implanted here, and systems, the bicable systems, to exclude the TR. Just like with a surgical valve, there will be a prescription for that person's anatomy in terms of what might be implanted for their tricuspid regurgitation. And with that, there will be different needs for different types of pacing approaches depending on their valve type. Now, clearly, there are a number of options to get a pacemaker in. You can go across the valve, as shown here, bioprosthetic valve. If you prefer not to cross the valve, you can implant using the coronary sinus, and there are various other permutations for high voltage. You can place that in the coronary sinus if you wish. There are issues about extraction, of course. And there are various hybrid options where there's a cold can and tunneled defibrillator coils. And of course, the subcutaneous systems and the leadless pacemaker systems, all options that we already know about and can use. And sometimes, if everything else fails, as in this case here, failed epicardial, failed endocardial, failed leadless pacemaker, we've actually implanted endocardially to the left ventricle. So not ideal, but these are all options. So that's the patient who needs a tricuspid intervention and then needs a pacemaker. The other group are those who have already got a lead across the valve. And this is where I'm very concerned. It's the jailed lead. Lots of excitement about how good these valves are, but lots of potential concerns for the future. Now, a lot of this really relates to how a valve is jailed. As you can see on the right here, the annuloplasty band is not jailing the lead, but edge-to-edge sutures are. So if that lead needs to be extracted, that means that those leaflets are very vulnerable. And as you can see over on the right, the lead is jailed against the native annulus by the prosthesis, subjecting the lead to force. I'd like to sort of illustrate my concerns with two examples. The first is this man here, who's got a relatively long history of pacing, who develops heart failure, valvular disease, gets a mitral and tricuspid procedure. A year later on, his RV lead fails. The center tries to manually remove the lead, fails, and puts a new lead in. And there's his x-rays, two leads going into the ventricle. And you can imagine what's going to happen. An eroded system, and he gets an infection. That means that the system has to come out. And as you can see on the CT, one lead is jailed behind the annuloplasty band. That's pretty straightforward, taking out the new lead, but the old lead is well and truly stuck by the tricuspid annulus. And this makes for a long day for me, because we have to do quite off-label things to free the lead using standard tools. And I'd rather not be having to do this on a routine basis. That lead came out without damaging the annulus or needing a plug, by the way. This is a second case. This is somebody who's got a very long device history, who undergoes an extraction because they develop ventricular arrhythmias and then has an ICD system in for 20 years. And this person then gets severe tricuspid regurgitation and is referred to another hospital without talking to the device doctors. So of course they get their bicable system put in, and within a matter of a few days there's noise on the lead, there's impedance changes, and there's a threshold change. And if you look at the X-ray post-implant, that's not too surprising. Look at the force that that lead is under. What happens next? Well, the doctors say, well, this person needs a device. So they describe how they put a new lead in through the superior limb of that cable system, which exposes that neo valve to potential damage. So we just don't know what's going to happen for that particular person, but I bet you their TR becomes more of an issue. So what we do know is that many of the papers talking about percutaneous valve procedures claim that the risk to jailing a lead is low. If you look at those X-ray images, you can see the forces that those leads are put under. My worry is that the percentage numbers are small, maybe 10%, but if you're vulnerable and if you think about long-term follow-up, we probably have a very large problem looming in the future. And the problem is, if we jailed a lead, how do we take it out if there's an infection? What do we do if the lead malfunctions? What do we do for the neo valve? Does the existing lead cause problems for that new valve? So how do we prevent that? We could extract the leads first, and that's certainly something that needs to be discussed. But remember, the longer a lead has been in, the greater the chances of causing important TR. That may mean a percutaneous valve can't be used. So it's something to think about. There are definite pros and cons to extracting before putting the valve in. What's really essential is that there's a need for discussion, and pleasingly, much of the literature now talks about a heart team approach. And as you can see, there are various diagrams and algorithms to help guide various team members through the process of thinking about the patient. One of the key issues is that it's a shared decision making, and missing from here is the patient, but a device doctor, a heart failure doctor, structural teams, very important, particularly when one has to think about the pre, peri, and post-operative care of that patient. Now, the European Working Group has made some specific recommendations about the need to be careful with certain higher risk groups, and as you can see, those red flags, the pacing dependent person, the person with high voltage leads, or somebody with multiple leads will need closer surveillance than others. So there are lots of things that are coming up that we have to be aware of. So I think we've moved away from the forgotten valve. Hopefully we're remembering about the lead, but we shouldn't forget about the patient, who is often comorbid, often frail, and I suspect with the popularity of these percutaneous valves, we're going to find we're treating at an earlier stage. So things are going to change over the next little while. We've got to address their needs from a valve and a device point of view. What I'm hoping we'll take away from this talk is that there needs to be an awareness of this as a looming problem, and we also need to make sure that we don't jail leads without thinking first. And if we do jail a lead, we need to think carefully about what happens if we need to take that lead out, because it's not a get out of jail free card that we've got here. So my challenge to you is to go back to your own hospitals, talk to your structural people, the heart failure doctors, the device doctors, about how you are going to plan for the upcoming widespread use of percutaneous valves. Thank you very much.
Thank you, Dr. Netolavo.